Hi, I'm Dr. Meagab Dwyer, and I am an associate professor and direct the Oncopsychology program at the University of Kansas Cancer Center and Medical Center in Kansas City. And I'm here to talk today a little about an overview of some mental health concepts, both for providers and patients, that I hope will be useful for you. Just a little outline and a little bit more about me. So I've been practicing in oncocytology for about 10 years now and see a range of patients, adult patients and caregivers at any point in their cancer care, as well as do training of psychology students and postdoctoral fellows. So I'm kind of coming at you from that perspective, though I hope a lot of the things that I have to talk about today will be applicable both in your cancer care, but across the spectrum of patients that you see, and hopefully a lot of things that will be usable for you as providers as well. So overall, I'm going to cover some common psychosocial problems and maybe how to recognize them in ourselves and in our patients. Obviously, this is not comprehensive, but these are probably some of the more common things, and especially these are things that I think have been amplified by our experiences with COVID-19 and how that's shaped our mental health as well. I'm going to talk about briefly some communication and supportive counseling skills for interacting with patients. And then I'm going to go over some both cognitive, but focus on a lot of behavioral strategies and tools that you can use now. Again, these are all things that you can use for yourself. And then I hope also you can disseminate those to your patient populations in turn. So one of the things that we have to consider with psychosocial concerns of patients is that I work really hard with all the patients that I see to normalize our emotions. So there are no good emotions or bad emotions, though we often conceptualize them in that way. Really, emotions are all natural. They're human emotions that are in response to our experiences. Those can be our external experiences, things that happen, as well as our internal experiences of processing memories, thoughts, concerns, worries, and so forth. So patients, especially cancer patients, we know that they come to us with a variety of concerns, often described as distress. We know that there's that distress screening mandate out from the COA, but patients often express as well anxiety and fear, depression, anger, and irritability. Those starred ones are the most common. They also experience a lot of side effects, both physical side effects as well as cognitive side effects, and even some medications and treatments can bring on some other kind of mood side effects as well. And patients are very concerned about the impact of their illness on their family. One of the themes that we know arises, especially when patients have more significant or severe illness, is they have concerns about the burden on their family, both the time burden for caring, the physical aspects of caring, the financial strains. So there's a lot weighing on people's minds. So one of the things we think about that is kind of on the lighter end is distress and adjustment. So within the diagnostic and statistical manual that psychologists and psychiatrists often use are adjustment disorders. And this is where distress kind of blurs into some functional changes, but maybe not severe. So distress and adjustment issues are often responses or reactions that patients or people have to current and or ongoing stress or changes in one's life. So this can be in response to an illness, the loss of a relationship, the loss of a job, changes at work, increased stressors that can come from, adding a child into the family. So it can really be a wide array of things that can force us to need to adjust, and sometimes that goes smoothly and sometimes it does not. Adjustment disorders or adjustment concerns tend to be a little bit more brief, and they are focused on or more related directly to that specific situation. This is often in my practice where I see patients who are otherwise very healthy, very well-adjusted, coping, adaptive people, and then the cancer diagnosis kind of throws them off balance and they need some additional help and support for processing that experience, revisiting coping strategies that they can use, maybe learning some new tools. So I find sometimes it's reminding patients of what coping strategies, what things have helped them get through prior experiences, so we can draw upon those and reflect on their resiliency. Maybe what things didn't work so great, so we can learn some new strategies, like if patients were turning to drugs or alcohol or other things, which are ways people try to cope but might not be as healthy or effective. How can we help them find some healthier and more effective strategies? Adjustment disorders and distress in general tend to be less impairing on our overall function. Maybe this patient is still able to go to work, is still able to take care of themselves, but it's kind of they're carrying this extra weight or emotional burden around with them. They're stressed, they're strained, they're getting by, but it's a challenge to do that. But it can still, even if they're functioning, this is the kind of stress and strain that can often still have an impact on their quality of life, their ability to enjoy things, or just feel like themselves or feel confident in their ability to manage things. So I don't want to make light of these concerns, and I think this is where kind of an ounce of prevention comes in, that when we're able to work with patients early on when they're adjusting to big changes, we can kind of set in motion and put them on a better trajectory to be able to deal with this and maybe avoid more significant depressive or anxiety related disorders or concerns. However, anxiety and depression are probably our next most common mental health concerns that we see in patients, but also in the population in general, right? The patients that we see, they're part of that general population. So there is quite a bit of overlap. I want to again stress the fact that anxiety or feeling nervous or on edge or having some worries or concerns is actually a really normal reaction to things, especially when we feel threatened in any way. If we feel vulnerable or threatened, our well-being, our health, our sense of security or safety, and also when we confront the unknown. And gosh, if this year hasn't been a time when we've been feeling a little bit more threatened, and we've been forced to confront a lot of unknowns and navigate that. This is a situation where I think it can be useful and sometimes adaptive to have a little anxiety. We go to a patient and we share, we really think you have to have this bone marrow transplant, and that's going to mean you're going to be isolated for this duration of time, and it's very risky, and these are the concerns we have, and they have no worries, no anxieties. That's fine, whatever. I'm a little more concerned. Now, I don't want to be a patient to be so anxious that they're having panic attacks or they're not able to function. But anxiety kind of shows us we're engaged, we recognize the risk, and then we need to use it. Anxiety that just sits and churns, so to speak, that I like to call it with my patients oftentimes the hamster wheel anxiety, where we're just churning, thinking it over, but not doing anything with it. We're not going anywhere, can be very ineffective and very taxing and exhausting. However, anxiety can sometimes also lead to motivation. It can give us the opportunity to address that thing, to seek help, to take action. If you can think of your times in schooling where you had a big test or project coming up that you were nervous about, sometimes that nervousness or anxiety also motivated you to say no to going out with your friends and sit and study, or to spend some more time reading or practicing for your test or whatever. So that anxiety doesn't have to be a negative thing, but it can turn that direction if we're not careful and aware of it. Some common signs and symptoms of anxiety that will show up. I think we know most of these, but oftentimes patients may be a little unaware of them. And that's where patients reporting some of those physiological signs might be worth a little bit more exploration on our part of what might be driving those, if there's anything on the mental health side. Obviously, our brains and bodies are very fully connected. And so, so how we're feeling emotionally, psychologically can have that impact, and vice versa. So on the psychological or emotional side, patients will feel worried. They may feel distracted. They can experience feeling irritable, short-tempered, or impatient, especially out of their normal range of emotion. This is someone who's typically not a super irritable person, but all of a sudden becomes on edge or is much more um, just reactive and negative. Memory problems can come up. This is often that memory and concentration are really tied together. Think of concentration as directing the camera, right? And then memory is recording. And if the camera's distracted, if we're moving it all over, all around, we can't record that thing, so we can't pull it out of memory as well. So sometimes when patients are reporting memory problems, once we do some cognitive testing or even explore that concept with them or explore the situation with them a little more fully, we often find that they're very distracted. And the source of that distraction is that they're in their head worrying about things and not really fully attending to the current time. I think we can all probably relate to pieces of time, maybe for ourselves, where we got some bad news or something was going on that we're still rolling around mentally and aren't attending to. You're thinking about this conversation or this upcoming meeting, and someone asks you for something, and you're just kind of like what did that person say? Okay, hold on. So it may feel that distracted feeling. It's hard to focus. I have to read or reread or come back to things, or I'm being more absent-minded. Those can also be signs of some anxiety as well. It can go as far as racing thoughts, feeling like our mind's just running away with us. That can definitely impact sleep. A lot of times patients will report, and many of us, our sleep can be impacted, that it feels like, oh, I didn't have all these worries during the day, and I go to lay down and then my brain's on and I can't stop worrying, which usually to me says I've been avoiding these things. Avoidance is anxiety's best friend. They work together all the time. And so oftentimes what will happen is a patient may be avoiding or trying to keep busy or distracting themselves from their worries throughout the day. And then when they quiet themselves to go try to lay down, the worry kind of knocks at the door and is like, hey, I'm still here, even though you haven't dealt with me. So we often can talk with folks about, spending some other time in the day to process worry, write down concerns, talk to or seek help, or use some other strategies to manage their anxiety or worry, so that it's not just right there pressing on them when they try to go to sleep. It can also go as far as intense feelings of fear or even panic. On the physiological side, obviously, patients experience sometimes in those more intense states that shortness of breath or rapid heartbeat. It can be muscle tension. We often carry that stress and tension in our necks and shoulders and can get really kind of stiff and sore and uncomfortable. Sometimes patients will experience nausea, even all the way to the point of vomiting. I've had several younger patients who maybe weren't really aware, as in tuned to aware their anxiety and having lots of nausea. And then once we kind of peel things back and start working on how they're feeling and really understanding the situation, oftentimes there can be some underlying anxiety. Feeling restless or jittery, it's hard to sit still, fidgeting, tapping our feet a lot, moving around, having a hard time wringing hands or playing with things. And also pain sometimes can be exacerbated by anxious feelings. So when is it too much anxiety? We know that anxiety is normal, that many of us experience it, and that it's actually a fairly normal response to those threatening or unknown situations. But too much for too long or in ways that make life harder can be a sign that it's time to get help or seek other alternatives of support. So problematic anxiety, oftentimes we'll see panic attacks or increasing frequency of those panic attacks. Avoidance, like I said, avoidance is anxiety's best friends. We get nervous and we put things off. When prime example of avoidance is procrastination is a form of avoidance, something that makes us anxious or we don't like to do it, we're uncomfortable, we kind of push it back or push it away. So when patients or we find ourselves avoiding aspects of daily life or parts of care because this can be avoiding coming to an appointment, avoiding doing something, avoiding taking medication because I'm worried about it or I don't like it or I don't like how it makes me feel. So anxiety can definitely play a role when anytime avoidance is present. And anytime anxiety is present, we want to look for avoidance. What are the things patients or we might ourselves be avoiding doing? We want to be very mindful when anxiety starts to interfere with our normal activities. Like it's hard to eat, either eating for comfort. So patients, both with anxiety and depression, we're going to talk about eating changes that can happen. Some patients, some people, when they're anxious, find themselves, eating absent-mindedly or seeking comfort from eating, and they're eating more. Other people will find themselves feeling uncomfortable or nauseous, so they don't want to eat. So eating changes, again, sleeping changes. With anxiety, much more often I see delayed onset of sleep or frequent wakenings. The sleep is really disrupted. It's hard to sleep and then they feel fatigued. It may be hard to keep their focus when they're trying to read something or watch a movie or watch television or doing something, or even having a conversation where, again, I'm so distracted in my thoughts or worries that I can't really hold that conversation or keep focused on what's happening around me. Depression, that next one. So obviously, again, a very normal response. Depression is often a feeling of sadness or grieving. That is a normal reaction to upsetting or unpleasant news or loss. And I want to focus again that loss can be loss of life, losing someone close to us, but it also can be loss of a sense of safety or security or normalcy, losing a job or not being able to function as well, feeling lost or disconnected from loved ones or friends or family when we're not able to do those things. Loss of identity aspects. If someone's always seen themselves as a golfer and now they lack the strength to do that, they can be very upset. They're in the psychology research, there's kind of equally weighted research that shows, is it kind of a chicken or an egg? Is it that we stop doing the things that we enjoy and then become depressed, maybe get an illness or something that sidelines us from doing things we enjoy, and then depression kind of takes hold? Or is it that we get depressed and then stop doing enjoyable things? And really the research says both can be true. So especially when there are major changes in a patient's life or in our own lives that sideline us for various reasons from being able to connect with those meaningful and enjoyable activities, mood changes are common. Some people can feel like I think we think about sadness or crying or even suicidal thoughts, but some people actually kind of go the opposite way. They feel very blasé. They feel they don't care about things. They just don't care at all. They can feel irritable or even numb, just not feeling at all. Especially if patients have a history of depression or are already being treated with an antidepressant. When patients report that numb feeling, to me, that's a good sign. We might want to revisit the dosage or type of medication that they're on, if they're experiencing that really flat or dulled mood. No highs, no lows, but just nothing. Be a very empty feeling for patients. So common signs of depression, I think we're often really aware of those things, but we want to be mindful of what that can look like. Definitely, like we said, sadness can be an aspect of it. It can be where it starts. It may not be what lingers on for patients. The irritability often still can come to play, where this is where the patient oftentimes can take on a more negativistic approach to things, like it's not going to matter, why bother, just leave me alone about it. It can be, just a very, very negative outlook on things. They can experience a lack of motivation or drive or disinterest. they become very negative in their and critical in their thought patterns and how they think about themselves. There can be sense of failure or burden, getting down on oneself in that way, and losing interest, again, as I mentioned before, in the things that they enjoy, even up to the point of having thoughts about death or dying, or thinking of self-harm, or feeling hopeless, that they don't find a sense of hope that in the future, or that things can or will change. Hopelessness is one of our biggest predictors around suicide. So thoughts of death and dying are not uncommon. Hopelessness, though, is something that often needs to be addressed, especially if it's severe and lingering. Physiologically, patients can feel tearful or crying spells, especially where it's like, I just feel so sensitive, or I'm crying for no reason, or it feels like no reason, or just the simplest thing can bring me to tears, or get me upset. Oftentimes, this is where with the sleep and fatigue, it can be excessive tiredness, feeling like they're moving slow, sluggishness, an increased need for sleep, but sleep that does not feel necessarily restorative, or just where they're spending a lot of extra time in bed, seeking that comfort, but not really getting anything from it. So they're just laying in bed. So with depression, while as I said, with anxiety, oftentimes we see like delayed onset of sleep or disrupted sleep where they're waking up in the middle of the night worrying. With depression, sometimes there can be difficulty sleeping, but oftentimes I find that patients are sleeping excessively, sleeping 12, 15, 16 hours a day. They get up and do something, they go right back to laying down. They're kind of living in bed or living on the couch. Definitely signs that we want to be more aggressive with going after the depression. Also changes in appetite. It can be less eating, it can be more eating, especially if patients are spending excessive times in bed and not taking care of themselves, and not eating well. That can be very detrimental to health, as well as to physical health as well as mental health. So when is it depression and not just a little low mood, or reacting to a loss, or kind of more of that adjustment period? So, some sadness or briefly feeling like you don't care is normal. We can all experience these things, especially when we've had, frustrations or difficulties, our expectations have not been met. Too much, again, for too long can, again, be a sign that it's more of a clinical situation, and we want to consider therapy and or medication management, depending on the patient's symptoms and what they're dealing with. Or, again, for ourselves as humans, being too tired, numb, or sad to get out of bed, kind of disengaging with life, lacking the motivation to complete self-care tasks, including hygiene. I think that's been something that's sometimes been duly useful for me in this era of telehealth, is sometimes I can see some more insight into the patient, maybe because they're not having to drive or come into an appointment. They may just sit in their pajamas and look like they just came out of bed, and they're not taking care of themselves. So we can't always assess that, or they may mask it sometimes. So that's been something that's been interesting, or in some ways useful, but something I want to address with patients. Feelings that slow, sluggish, stuck in the mud. It's hard to get moving. I have no energy. I just can't do it. Again, lack of enjoyment, especially if it seems prolonged, not just for a day or two, but it's going on for a couple of weeks or more. And then obviously thoughts about death, suicide, or self-harm behaviors are red flags, and hopelessness as well. And we want to address those, or encourage the patient to get help. So what are some common factors that patients experience in all of these things, in anxiety, depression, and illness? So often there's that fear of the unknown. I don't know what's going to happen. I don't know how long I'll have with this cancer. I don't know what the side effects of this chemo are going to be. I don't know how I'm going to manage if the school locks down again. I don't know what I'm going to do, that fear of the unknown. On the flip side of that, sometimes patients, especially if they've had like a relapse of disease or something, they have the fear of the known. They know how hard it was. I often try where I can to use some cognitive reframing for patients of, while yes, you know this was hard. Also, you got through it. Let's think about what helped you get through it. It may not have been an easy getting through, but reflecting on that resilience, reflecting on their coping skills and helping to regain some confidence. But it's understandable. They know what's coming, or they know how hard it was. I can think of that for many of us who are parents, of knowing the challenges of dealing with homeschool or adjustments to our work life schedules, and just the craziness that this year has been. So we, at first it was, I don't know what's going to happen, it's scary. And now we've known how hard it's going to be and how much longer can we do it, or if we have to do it again, if there have been breaks in that. They can have grief for the present of things that they thought they should be able to do. I know for a lot of patients that's been a challenge of not being able to connect in the ways that they're used to. Loss of identity function, loss of plans, frustration with those changes. Our frustration, it's a very Buddhist kind of concept, but it's a very true thing, that the further away our expectations and reality are from one another, when we have this expectation of what things should be or ought to be, or what I expect them to be, and where I am, frustration really intensifies the further those things go. So that's something I often work with patients on, is what are gentle ways we can set realistic expectations and then set goals to move your reality closer to those. But that can be a particularly challenging thing and can trip patients up quite a bit. Grief about the future, the threat that they have to their hopes and dreams of maybe getting to see a child grow up or accomplish something, travel, kind of the things that they had hoped or thought they would have. That potential and possibility can feel really impossible. Something I work with patients on is widening that hope of what else aside from, the sliver of just the miracle of survival, but also what are the other things you hope for, and how can we bring those to light for you? The physically they're feeling bad. So in anxiety, depression, and illness, we don't feel physically great, and they can amplify when we're experiencing them together. And then there's that anticipation of what's coming, or I kind of see ahead what, and having that fear and anticipation there. So when we're talking, I hope we're going to kind of switch gears of, now we know what some of these things are. I think those are probably very common, and that you guys as an audience are very well aware of. Gosh, I can't talk. Well aware of, but I think we can always use a good refresher and reflect on ourselves and our patients and those around us. So ways to communicate, some core communication skills between medical staff and patients that can be helpful. Really one of the things that on the psychology side, and I'd say we do a lot of conversing, that's kind of our wheelhouse, is talking with patients, listening with them. But on the bottom there, I wanted to include that to just really focus on that values, and that oftentimes understanding the values behind what patients are doing, the decisions that they're making, the beliefs that they have, can really help us understand and communicate with them and help them navigate some really sticky situations. That can be when we're breaking bad news, spending time with patients, discussing their prognosis with them. I know that can be a challenge, but asking them, is this something it would be helpful for us to talk about? What do you want to know about your prognosis? Recognizing that it's not going to be exact, but how can we help you and your family best prepare or take action if there are things that you want to accomplish or do? I will say on the psychology side, when I'm working with our cancer patients, it's very challenging when patients maybe haven't had that conversation, and then they're getting, kind of very late in the game, the news that there's nothing more we can do. You're going on hospice and have, maybe a few weeks to live. And they say, I would have done XYZ if I'd only known. Now, sometimes I know that medical teams that you guys try your best to communicate to that to patients, and because of denial or misunderstandings or just not taking in all the array of information that they're receiving, that maybe that they've been told but didn't really understand or take it all in. I think values again, can be a really great piece to come back to when we're discussing benefits and risks with patients. And when we're talking about sharing the decision making with them of what we think is best or not, or here's the risk. I've had patients, something I talk with a lot of my patients, especially who are in more chronic management phases of disease, is, we're using this treatment to help you live. We shouldn't be living to take treatment. And so how can we make sure you're still living, you're still enjoying things that are important to you? And it does not mean talking with your team about the risk or benefits. If, obviously COVID's really sidelined a lot of these things, which is a challenge, but thinking about, okay, if you really want to attend your granddaughter's wedding and that's going to push back your treatment a week, what are those risks and benefits? And is that of such a high value to you that you're willing to take on more risk? I think we see that sometimes right now as patients are, and all of us are navigating the risks around COVID. We're all navigating risk all the time. It's just much more in the forefront. I think of driving risk. We all are navigating. There's always the speed limit, the general suggestion that we should be driving. And then people kind of assess their value and comfort with taking risk and driving over that speed limit, maybe by a little bit or maybe by a lot. And we all kind of judge how other people value or approach that risk. George Carlin had a great joke about no one drives correctly but yourself, and anyone going faster than you, kind of a jerk. Anyone going slower than you is an idiot. And you get stuck behind idiots and get passed by jerks. He used a little bit more colorful language, but we're all kind of navigating risk and benefits based on our values, and sometimes that can help. And I think that's where sometimes patients and IC teams get maybe into a little bit of tension with one another when we don't know why the patient's making this seemingly risky choice, and it may be because it's really more aligned with some other value, and we may be able to find a healthier middle ground or an option for them. Be sure to respond to emotions, even if it's just acknowledging them. We'll talk about that. Points of conversation where we're talking about transitions in care need extra time and attention. When we're talking with the family, engaging them, because then we've got a lot of people with a lot of different values, different opinions, different beliefs around what should be done, and where we can refocus them on honoring the patient's value and what they want, especially then when it comes to discussing death and dying. We know that talking about death and dying is actually not harmful to patients, and that open conversations about death and dying that honor the patient's wishes and allow them to process it can be both helpful to the patient as they approach death, but have also been shown to be beneficial to the patient's family in the year to 18 months after a patient passes, where families who had more open and supported discussions with medical teams about death and dying show that the family members experience less bereavement problems and less depression after their loss because of those conversations being useful to them. So if you feel like, oh, I don't want to talk about this, it's going to harm or it's going to hurt the patient, or it's hard, but it actually can be really useful and beneficial. So some of the basics of those communication skills that I know we all know, but we can always use a refresher. It's practice, right? Practice means that we're always improving, which means we're going to stumble and get it wrong sometimes. Practice means it's not going to be exactly perfect all the time, which can be kind of freeing to say, okay, not that we give up on doing better, but that we don't force ourselves, we give ourselves some grace that we're going to be improving in all these areas. Reflective listening. If we don't know what to say, just listen and reflect back to the patient. Helps them feel heard, helps you connect, and helps you make sure that you are understanding what they're saying. If we're talking to patients about risk, prognosis, or really more technical things, asking them to teach back, asking them to say, can you tell me in your words or how you might describe it to a friend what we just talked about with your treatment or this risk or what you need to do with this medication. That can be a great moment to ensure that the patient understands things. We can clarify any things that the patient may not have understood or may not have comprehended. So that teach back moment of having them restate in their words their understanding of things can be really important. I've seen this many times where a team may be gently trying to say, we really think that even with this treatment, we're looking at only 6 to 12 months. And when we do a teach back moment, maybe the patient or maybe a family member goes, I heard that this treatment will get you at least 12 months. Okay, well, we might have to revisit that, or let's talk about that a little more detail. So that can be a great moment to ensure we're all on the same page, um, and 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 then opportunity to correct. Honoring and acknowledging emotions and values. I know this is really hard to hear. I know this is upsetting. Um, what are your values and how can we help you connect to those, or what's most valuable to you? What do we need to be doing to help you in that area? And then eliciting change talk. I hear that this is a problem. What would you feel comfortable doing about it? What do you need help, and what do you feel comfortable in doing yourself? I think where we can take it out of a blame talk to a change talk can be important. If you're interested in that or think it might be helpful, obviously I would direct you to reading up more on motivational interviewing, or do some training in that area. It can be really useful for helping patients who are stuck kind of making decisions or moving forward, especially around habit change like smoking cessation, or quitting drinking or other things, or even weight management, or managing a chronic illness, that where we can help the patient move towards change and ownership, and feel the confidence to make changes as well. So tools that you can use right in the now, right? We all want to fix it right away. Not everything gets fixed quickly, but I wanted to be able to wrap up with some take homes that I hope will be useful for each of you, but also for the patients that you're caring for. So here's some kind of, when we think about like cognitive behavioral therapy, that's definitely an area I have a lot more training in, but and some other things. But we know that thinking, how we process, and the way we think about things definitely has an impact. For anxiety, a lot of times we get stuck in the what if cycle. So 3 really, really brief strategies that I use with patients and try to utilize myself when anxious or when worried about something is these 3 challenges to what if. Anxiety focuses on what if. Response to that is always something negative in the future, right? What if the cancer comes back? What if the school shuts down? What if we run out of ICU beds? What if? There's so many what ifs that we're all kind of in the healthcare systems dealing with. So one way to break that down is what if not? Especially for cancer recurrence, we talk with patients about using these tools of, what if it comes back? What if not? What if the treatment doesn't work? What if it does? Is reminding patients that whatever anxiety is telling them is not the only option out there. Anxiety is usually a very inaccurate forecaster. Very rarely do our true exact anxieties come true. There are always exceptions to that, but we're inaccurate more times than not. So reminding ourselves that whatever worry is telling us is not the only possibility out there, and the inverse is possible as well. Focusing on what if, which usually takes us out of the current moment into that foreseen future that we're trying to predict, to what is. And that's kind of using that mindfulness of, is our mind kind of a slurry of all these other things that aren't happening, and can we come back to right now? What if what if I have a ton of side effects? Okay, right now I'm not. Right now I feel okay. It can come back to what is of just today, all the way down to this very moment of what is that I'm sitting in the seat, talking with you, going through the presentation. What is happening right now? Being in touch with that current moment versus anxiety that pulls us ahead and distracts us. And the last one is and then. Instead of arguing, debating, or trying to change anxiety's mind, we agree. And we say, okay, and then if that were true, what would I do next? This is a great way to try to help patients recognize both their own strengths in coping and the resources available to them. I would call the doctor. I would talk to a colleague. I would go for a walk. I would, I would look at the literature to see what the resources out there are, what else has been tried. So the and then kind of helps us look down from the cliff, remembering either that we can fly, have our abilities to cope, or that there are a lot of resources and supports, be it expert supports or our friends, family, and colleagues around us to support us. It's hard to ask for that help, but it's often there and closer and more willing than we realize. When we think of the more depressive side of things, when patients are experiencing low motivation or just some anhedonia, they're not engaged, they're not interested, they're not enjoying things, they kind of decide ahead of time that things are going to be bad. So one of the things I encourage patients to start from is I can't guarantee if you try something, it will make you feel better, right? I can't guarantee that, but maybe it will. And is it worth that? So I often encourage patients or encourage us to kind of sit from that first point of curiosity. You know, here's little Curious George. I have 2 young kids at home, so we have a lot of Curious George books laying around, you know, and George is always curious. He's always trying to find things out or figure things out. Hopefully we won't get into quite as much trouble as he does or have a better overseer than the man with the yellow hat who's seems a little circumspect there, but being curious is I wonder how I'd feel if I called my friend. I wonder how I'd feel if I went for a walk. I wonder how I'd feel if I did, you know, 5 minutes breathing exercise. I wonder how I'd feel if I wonder how it would be. And just seeing if we could sit with wonder and curiosity and try. And if it works, fantastic. Let's reflect on what works and what doesn't. And if it doesn't, effort is still worth it, and we appreciate that effort. And I find that oftentimes, you know, the body's in motion tend to stay in motion, bodies at rest and stay at rest. And once a patient can approach curiosity and try something, if it works or doesn't work, they've often put in motion their willingness, and then we can kind of grow on that. Okay, I wonder how I'd feel if I got out of bed and took a shower. Well, now that I'm already out of bed and I've showered, I feel okay, and now I might as well sort the mail while I'm up, and I might as well, and it can kind of put some things into motion for us that can feel too overwhelming to think of doing my whole day, but doing it one little piece at a time can be much easier. Tapping into our brain systems. So we know that these brain chemicals are kind of involved in our in well-being. You know, serotonin is involved in mood. Dopamine is that reward that gives us a little boost, that reward system. Oxytocin, that love chemical that helps us feel warm and cozy and good. Endorphins that can help us enjoy things and promote pleasure and help us manage pain. And aside from medication or the chemistry of this, there are some behavioral things or things that we can do and take action and have a say in. I hope that this is something that says I can feel empowered. There's something I can do. With serotonin, we know that eating protein-rich foods can increase serotonin. Aerobic exercise, even brief aerobic exercise, can increase it. Exposure to sunlight, especially as we're going into these winter months, either making sure we do get a few minutes outside or using a light box, which now are much less expensive. You can find them online for $20 or $30. Want to follow the instructions, making sure we're getting enough time and sitting close enough to them, but those can be options. Also sitting with positive imagery, using positive imagery. It can be an image we create. It can be reflecting on a happy image or a happy memory. But that sitting with that for a few minutes has actually been shown to increase the brain's level of serotonin and help with mood. The dopamine reward system, tyrosine-rich foods such as cheese, nuts, avocados, I think bananas is in that list as well. Those kinds of foods can definitely impact dopamine system. Again, exercise, moving the body around can be good. Meditation sitting and meditating, which is not necessarily empty mind as much as awareness, mindful of what's going through my mind, noticing in a non-judgmental standpoint. I've been very pleased to see how much mindfulness and meditation is taking off. So even a few moments, and we're going to talk to some apps here in just a second, but There are a lot of great tools to get started on that. Even at 5 minutes, 10 minutes, you don't have to meditate for 2 hours for it to be effective. Even short bursts can be useful. Massage or touch can increase our dopamine, and having sex can increase our dopamine. So something that we have action to do. We may not feel like doing it at first, but definitely can increase those levels. Oxytocin, or that love, connecting with friends or loved ones. Obviously right now we know that can be such a challenge, but making sure that we, if it's video calls or standing in the driveway talking or finding ways to connect, we might have to get a little more creative, but that connection is really important. Snuggling with a pet, or you know, petting your dog or cat, or spending time with them. I think we can all, you know, if you sit, maybe you're at your house right now and your dog or cat or pet is around you and you can really connect with this. But if you even just kind of think of that feeling of cuddling with a warm little fuzzy animal, can give us that really good release. Hugging someone you love or someone close to you if you're able to. That's, I know, another challenge right now. But also we know that giving activities, that we receive a little boost of oxytocin in giving a gift or doing something nice for someone, holding the door for someone, saying thank you, that giving or generous acts tend to also increase oxytocin in the brain. And then endorphins, again, exercise, sex, dark chocolate, a hot shower or bath, engaging in laughter, watching something funny, doing something that helps you to laugh or connect with others in that way can give some levity and increase those endorphins. So something I want to point out on here, and on a couple of the articles that links that I put to some of this information that's important to note is, you know, across this, exercise obviously is a good one when we can find time, but it can be brief, but moving our bodies, I think, noting that, and that engaging with technology, our phones, our computers, and so forth, aren't really tapping into these systems. So maybe being aware of limiting our screen time or limiting our use of technology to re-engage, because it just doesn't give us the same benefit as some of these other activities. I want to talk, just as we're kind of wrapping up, on two things: recognizing floors versus trampolines. So floors, if we think about it, right, floors are stability. That's where things go up from there. So the floor is the basic, is the bottom. It stops us from falling down or going down further, but it may not necessarily boost us up. It's not an increase or raise. So it's just meeting these basic wellness needs. We know that for human basic well-being, Maslow's hierarchy, those lower levels that are just our basic well-being, that we need sleep, eating at least some healthy foods. I'm a chocoholic, I will admit to it, but I know I need to make a few healthy choices throughout the day, making sure we're eating well, hydrate, making sure we're drinking enough water, taking care of ourselves in that way, making sure we're moving, if it's going for a walk, doing some light stretching, trying to get in a little bit of exercise, but that moving our bodies around is that basic need. We need to do that for our well-being, our factory set bottom level, and that we need to connect with others. We are wired to be in connection with other humans. You know, historically, we know, and even up to today, that, you know, the most punishing thing that a human can experience is shunning or solitary confinement, right? These are the highest levels of punishment cross-culturally and historically that we do to people, aside from taking someone's life. But if you're going to be living, expulsion from the group is the most dangerous and challenging thing, and really impacts our wellness. So finding ways to connect with loved ones, colleagues, friends, neighbors, whoever it may be, that connection is really vital to our wellness, our basic wellness. But trampolines, okay, we might need more than that, especially through these hard times, this really challenging year. And I laugh that I'm recording this today on Friday the 13th in 2020, which, fingers crossed, my goodness, of course 2020 has these Friday the 13th dates. Right, but we need a little more than just our basics met. We need something to sometimes energize us, to improve our mood, to give us a boost, to actually charge our batteries, charging them up all the way. A lot of activities that we used to enjoy that charged our batteries, like going to the theater, going to a concert, going out with friends, being much traveling. This year, a lot of them are not available, or they're really peeled back. So we might have to get creative. Um, so I think obviously if you're a Parks and Rec fan, you may recognize this treat yourself episode, but they're really, Tom's really on to something here, and uh, around that we do need a little extra. Now, I'm not saying it has to be spending money extra, but that these are activities, thinking of things that connect us to our own values, or connect our patients to their values. What connects me to the things that are most important to me, to my family, to my friendships, to learning, to art, to music, to whatever we find is really valuable and brings about enjoyment, a sense of gratitude, or peace. And sometimes we need to recognize that just getting those floor needs met, it's good. I don't want to fault those floors, but it may not be enough, especially when we're under a lot of stress or strain. We may need that trampoline. We may need that boost, that something a little bit extra to do for ourselves. It doesn't have to be big. It doesn't have to take a ton of time. Making that choice and enjoying it fully, of 5 minutes to just have that piece of dark chocolate that you really love, or 10 minutes to send a couple of funny memes back and forth with a good friend and connect. Just doing very small things, but reminding ourselves that we may need those, charging our batteries to keep going. I know there was another speaker on burnout and compassion fatigue and those topics, so I hope that some of that will tie into what I'm talking about here, but that we can't light ourselves on fire and expect to keep other people warm for long and not experience a lot of burn. So taking a little bit of time to treat and take care of yourself is important. Some mobile apps that I think can be useful. Can't say enough about COVID Coach. It's an amazing free app, tons of resources on coping with all of these different things, managing mood, anxiety, sleep, mindfulness tools, parenting tools. It's great. It is free. I have no connection to them, but I've used it. I've shown it to friends, family, all my patients. Is a great app. Virtual Hope Box, Mindfulness Coach, Mindshift, and Happify, or Mindshift, excuse me, and Happify. All great apps, all are free. I encourage you to maybe download or play around with them, find what you like, recommend them then to your patients, to others. I know that Calm and Headspace have some free options, and I think also some discounts for healthcare professionals. They are great apps too, very based in the research. Calmany is another one, and 10% Happier. So these are apps that there is some cost for, but again, some of them do have some discounted rates. But a lot of times you can do a trial subscription to see if it's something that you are going to use or enjoy, but a lot of great tools that then we can have right in our pocket at any time to utilize. Some references, and obviously there's some other references I can add to this. If you have questions, I'm happy to answer those, hopefully, and then also happy to give additional resources or references as needed. Thanks so much for your time today, and I hope this has been useful for you.